joining today's educational webinar with Cancer Support Community Los Angeles. I'm Abby Espinoza, the Program Manager at CSCLA, and I'm honored to welcome you to this week's webinar titled Children's Oncology Group, Long-Term Follow-Up Guidelines, Updates for Patients and Families. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you'd like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org. Before I introduce today's speakers, please note that your video and microphone are automatically disabled for this webinar. Please enter questions for the speakers into the Q&A feature found at the bottom of the Zoom window. Questions will be answered at the end of the presentation. We may not be able to get to all your questions today, but we will get to as many as possible. Please use the chat feature to share comments and resources with other participants or to ask questions of CSCLA. We ask you to limit chat comments to information relevant to this topic. Lisl Schweers is the lead psychosocial clinician for the Life Cancer Survivorship and Transition Service in the Cancer and Blood Disease Institute at Children's Hospital, Los Angeles. Ms. Schweers is a member of the Board of Oncology Social Work Certification, serves on the Professional Advisory Board for the Cancer Support Community Los Angeles, and facilitates the Survivorship Special Interest Group for the Association of Pediatric Oncology Social Workers. Ellie Rosenthal received her bachelor's and master's degree in nursing at the University of Pennsylvania. Ms. Rosenthal has been working in oncology at Children's Hospital Los Angeles since 2001. For the past 21 years, she has been a nurse practitioner in the Life Cancer Survivorship and Transition Program. It gives me great pleasure to welcome today's speakers, Lisl and Ellie.
Again, thank you, Abby. Thank you, Jennifer, and all at Cancer Support Community. We're delighted to be speaking with you today, sharing information that is evidence-based and also based on our experience. Both Ellie and I work in the Cancer Survivorship and Transition Clinic at Children's Hospital. We are a team comprised of physicians, nurse practitioners, social workers, and we have on consult dietitians and neuropsychologists. We have clinic about 3 days per week, and we see patients annually for the screening of late effects. We screen for both the medical and the psychosocial late effects. And so we're going to be talking to you today about what those primary late effects are, how we screen for them, and how we can help you manage life as a cancer survivor or a caregiver of a child with cancer. Slide isn't advancing. Let's see. Okay, there we go. As I mentioned, both Ellie and I work at Children's Hospital Los Angeles. However, this information that we're presenting today do not necessarily reflect the views of Children's Hospital Los Angeles, and it doesn't constitute an endorsement by CHLA of our views. However, we are presenting information that are evidence-based and also based on our sort of 30 plus years of experience combined as a social worker and nurse practitioner together. Just to give you a brief overview, we are going to do a little bit of a explanation of exactly what are the Children's Oncology Group long-term follow-up guidelines for child, adolescent, and young adult cancers. We are going to explain the history and why they're so vital to know about in caring for childhood cancer survivors. We're going to talk about the recent updates that were published in October of 2023, both the medical and psychosocial late effects that we screened for. And then throughout the presentation, we're going to discuss the screening, some resources that we use to support our families going forward.
Okay, so these are the new guidelines from the Children's Oncology Group. This is the front page with an introduction to our guidelines. And this was put together by the Children's Oncology Group with the mission to cure, prevent childhood and adolescent cancer through scientific discovery and compassionate care. These follow-up guidelines were developed. First version was in March 2003. And there have been 8 versions total, with the most recent version being released in October 2006, and it's officially version 6.0.
2023, you meant.
Yeah, 2023, yes. So what these guidelines do is they provide recommendations for screening for potential late effects. Children receive various different types of treatment for their childhood cancer, radiation, chemotherapy, surgery, some targeted chemotherapies, BMT, CAR T-cell therapies. And these guidelines are to make our patients and families aware of potential late effects, what they're at risk for, so that we can keep them as healthy as possible now that treatment is over. And these guidelines are standardized, throughout, the whole country through the Children's Oncology Group, and covers the lifespan after treatment. The guidelines are put together by a panel of experts in multiple specialties: physicians, nurses, social workers, dentists, physical therapists, psychologists, as well as different subspecialties, endocrinology, cardiology, orthopedics, who are all familiar with potential late effects in cancer survivors. These have been updated about every 5 years, and these guidelines can be found. They're available to anyone, patients, families, physicians, on the Children's Oncology Group guidelines, and we will give you that website a little bit later. They're recommended to be used within the first few years off treatment in our clinic. Our goal is to see patients within the first year after completing therapy. So that's when we encourage our primary oncologist to send them to our clinic. Here are some examples of some of the changes with version 6.0. So, anthracyclines are a type of chemotherapy that's used to treat various different types of cancers, from leukemias to osteosarcomas, Ewing sarcomas, and the new change reflected for patients who receive a low dose, which is, pretty common for standard risk ALL patients. So patients who receive less than 100 milligrams per meter squared and or radiation less than 1500 centigrade, no cardiac monitoring is needed. And that was a really big change for us with this last change. And then there was also, there is a dose conversion for all the different types of anthracyclines, with doxorubicin being the standard. Previously, mitoxantrone was considered ×4 stronger than doxorubicin, and the new guidelines is now ×10. So in patients who receive mitoxantrone, there is an increased risk of cardiotoxicity that we've had to discuss with our patients as we are seeing them, since those guidelines have changed. And previously, methotrexate was felt to be to put one at risk for reduced bone mineral density, osteoporosis, and with this new change in guidelines, that recommendation was removed. With the alkylating agents, they added a dose equivalent calculator, with cyclophosphamide being the standard, to determine which patients are at higher risk or lower risk for estrogen, testosterone hormone related, and fertility late effects. So that is new and helps us to guide who would be higher risk for these side effects. And then adding subsequent malignancy, risk of malignancy in offspring. There are some cancer treatments like radiation, going through transplant, that can make you more likely to develop other types of cancers as you age. So we are educating families about that. There are also cancer-causing genes, and we'll talk a little bit about that later, but increased risk of a secondary malignancy, say for retinoblastoma patients, P53 mutation, and then the risk of passing that gene on to their children, and their children being at higher risk for developing cancers. The next two are new recommendations that were added with version 6. So there are medications called tyrosine kinase inhibitors, imatinib, dasatinib, nilotinib, and the recommendation is for screening for hypothyroidism, growth failure, and delay, and then with some immunotherapy like rituximab, concern for decreased immune function. And they have found that some patients who receive rituximab have needed to receive IVIG to help boost up their immune system after treatment was completed. So those are some of the new ones that were added in version 6. So at each visit, we review each patient's cancer history, what their recommendations are for the future, and let them know what testing consults are recommended based on what their treatment regimen was. So before we see a patient, we do a lot of work. We go through their chart, calculate what chemotherapies they had, how much of each chemotherapy, where their radiation was. Based on that, we put together our summary note, and we will show you an example of the summary note with the recommendations and summary of chemotherapy. And then it also lists what testing we're ordering afterwards, like echo, EKG, audiogram, and this is all based on risk profile. So echo, EKG, if somebody had anthracyclines, audiogram, if they had any of the heavy metals like carboplatin, cisplatin, and then also subspecialty referrals that we make at each visit, not necessarily, but neuropsychology for our patients treated for leukemia, cardiology if they're high risk for heart defects, endocrinology, ophthalmology, various different referrals, physical therapy, OT, school advocacy, behavioral health, and neurology are some of the most common ones that we do make in our clinic on a regular basis.
Okay, so the guidelines, there are probably, I don't know, 50, 60, 70 sections. The first 7, section 1 through 7, really are intended to cover any treatment exposure. So for any cancer experience, whether it's a child or an adolescent whose treatment just includes surgery, or even the patient that receives chemotherapy, radiation, transplant, the research has borne out that there are common late effects that may be presenting themselves with any kind of cancer situation. So the first one is the effects on the psychosocial functioning and quality of life. This may not be too unusual for many of you, but social withdrawal, educational problems, relationship problems, underemployment, unemployment, dependent living. You know, the social withdrawal we see as children are not necessarily able to keep up with their peers. Maybe they can't go to school for long periods of time. They don't necessarily learn how to make friends, how to maintain and establish friendships, simply due to their time spent at the hospital, coming to the doctor, being immunocompromised, not being able to go in places where there are large crowds. So that is something that we see quite regularly. There are survivors who are at risk for underemployment, unemployment due to a decline in their overall functional ability. Perhaps it's a situation where they got behind in school, or they really suffer from, problems with low self-esteem, a fear that they're just not going to be able to keep up with their peers. So we see kids who sometimes get held back in school, or they have to work really, really hard to get caught up. And that just puts them at higher risk for having challenges later on with employment. We have patients who have disabilities as a result of the cancer diagnosis or the cancer treatment. We have patients who maybe develop a sensory loss, such as eyesight, hearing. We have children who receive treatments that affect the neurocognitive development and just any, physical impairment. So we work with families to assess what the strengths are for each patient, but also look at the supports they're going to need as they develop and move through adulthood and developing supports that they may need. Going further, let's see. Section 2 describes some of the most common mental health disorders that we see. That doesn't necessarily mean that every child with cancer, every family experiencing cancer diagnosis is going to suffer from full-blown diagnoses, but we do see a fair amount of symptoms. One thing we didn't know at the beginning, but estimates show that at least 2/3 of all cancer patients and survivors will develop at least one late effect. So it may not be a physical condition, it could be an emotional or behavioral health condition. We do not only screen the child, but we also explore family functioning. How are the parents coping? How are siblings doing? We see anxiety related to body image, self-esteem. We see health-related anxiety. There's a term called scanxiety, right? Fear of coming back to the hospital, fear of recurrence. We see some post-traumatic stress symptoms. Those could present themselves in avoidance, just kind of shutting down, not wanting to come for follow-up, kind of ignoring all the potential problems that may develop later on. It could be just a hyperarousal and just really having somatic symptoms when they think about coming back to the hospital. What's new in version 6.0 is the point about suicidal behavior. As we know, there is across the nation and in the world, we are seeing more and more children and adolescents being impacted by traumas of all sorts, including medical trauma. So depression left untreated, unchecked, can sometimes lead to suicidal ideation, thoughts of just not wanting to live anymore. And so we want to make sure that we do screen for any kind of suicidal thinking or suicidal attempts at visits where we worry about a child's mental health. Let's see. Also, we know that cancer doesn't happen in a vacuum, right? So we have children and families who are experiencing poverty, stresses related to divorce and separation of caregivers, unemployment, job loss, maybe related to having to stop work to take care of a sick child, immigration, you name it. So, you know, cancer is just something that can actually compound and deepen the stresses that are already being experienced by a family. So the upside is we don't see a ton of this. We do a lot of psychoeducation where we prepare children and families that these are things to kind of look out for, not just one time when they come to clinic to see us, but just normal, you know, mental health behavioral screening that we can all do with our children, and we can make the schools aware of these things as well. Risky behaviors is another late effect that we are encouraged to screen for in children and adolescents treated for cancer. These are behaviors that we know that can lead to harm on down the road. You know, risky behaviors, we think about substance use, vaping, you know, sexual behaviors that are you know, not well thought out and not well planned and managed. So we have a model whereby we look at harm reduction, and we know, for example, something like cannabis is used widely in oncology for both symptom remediation, for pain relief. And now that we have medical cannabis and recreational cannabis that's much more available to our patients, we need to do counseling around perhaps alternatives. If someone is choosing to use cannabis for an anxiety or depression or some other mental health concern, we look at other forms of treatment. If we know someone is using cannabis and it's working for them in some way, we talk about choosing alternatives to inhaling smoke. So again, that's looking at a harm reduction model. If we have a young person who is engaging in high-risk sexual behaviors, we talk about the importance of protection. We also talk about the importance of preventing pregnancy. There's sometimes a myth that, you know, chemotherapy has caused me to become infertile, and so it really doesn't matter. I don't really need to use protection. So again, it's really providing that education to young people, even as early as age 13, 14. We know that kids want to fit in. They want to experiment. All their siblings, or I mean, excuse me, not siblings, but their peers. So sometimes there's pressure too. So that's something that we want to keep an eye out for. Ellie's going to talk about pain now.
So it's very common to experience pain, not just during cancer treatment, whether from the cancer itself or, from the cancer itself or from the treatments that they may receive. It can be caused by damage to bones, joints, nerves from the treatment. Some examples are avascular necrosis from steroid therapies, back pain from multiple lumbar punctures, amputations and limb salvage surgeries, which cause leg pain, hip pain, back pain, difficulty with ambulation, and scar tissue pain. And we assess for pain at every visit as part of our history and make referrals as needed. There are lots of different referrals available to them: pain clinic, orthopedics clinic, as well as psychosocial, psychological consultations as needed, available to our patients.
Before I jump into section 5, which addresses fatigue and sleep problems, I want to go back. The first slide that I showed you indicating the adverse psychosocial and quality of life effects. I had 2 images on there, if you recall. Those were photographs that I took at Camp Ronald McDonald. And I want to point out, it's really important to understand that for every late effect, there is a plan to monitor, but there's also a plan to treat. So when we have children who have emotional difficulties, social anxiety, just really needing encouragement and support in developing those healthy peer relationships, exploring age-typical social and recreational activities such as sports and getting involved in music. We refer to resources in the community for that. So Camp Ronald McDonald is one of our local oncology camps that both patients and long-term survivors are eligible for. And those programs also include opportunities for parents and siblings to also get that support and benefit from that experience. There are local programs such as Coach Art and Pavlov Shutterbugs, which provide extracurricular or after-school programs for children to learn how to play the piano, how to play tennis. There are art classes and cooking classes. And I want to point that out because these programs are run by folks that really, really know what our patients have been through, and they provide these activities in a very safe and supportive environment. And they are then they enable children to interact with other kids who may have had a similar experience, and that kind of reduces the overall isolation of having gone through cancer treatment. So I just wanted to point that out. But going back to sleep, increasingly we know that sleep is a very vital function as a wellness behavior, along with exercise and nutrition. So at every visit we explore problems with fatigue and sleep. We do need to rule out any sort of medical or organic cause for sleep, and our medical staff do a great job of that. But as is common, there are sleep problems, there are difficulties falling asleep, staying asleep, nightmares, problems that really interrupt getting a full night's sleep. We have a lot of patients who have a heavy homework load, so they're staying up late, or they're choosing to maybe be on their phone or just do something else besides sleep. So we do a lot of education around sleep hygiene. We talk about consistency, the importance of trying to go to bed at the same time, waking up at the same time, and getting a good 8 or 9 hours. We talk about the importance of a suitable environment that's quiet, that's dark. We encourage limiting sugar and caffeine take later in the day. We discourage napping during the day. But a lot of it is just, there's some rumination. I know we all can experience, thinking about the day we've had, thinking about problems or responsibilities that we have. So I encourage my patients to not completely ignore those things that they're worried about, but maybe write them down so they can just revisit them the next day and reassure themselves that they're not going to forget, that they can pick up the worry where they left off in the morning. But sometimes that helps, in addition to teaching skills related to relaxation, breathing exercises, guided meditation, and those kinds of things. Number 6 is probably something that just about everyone is familiar with, but we see limitations in healthcare and insurance access. Especially in the US, we know that accessing insurance can sometimes be tricky. If someone has insurance through their employer, that's one way to get insured. However, I think at least in LA and at Children's Hospital, the majority of our patients are receiving some sort of public funding for their insurance through Medi-Cal or California Children's Services. Those programs do have income guidelines as well as insurance plans that are purchased through the marketplace through Covered California. So at every visit, we do assess the stability of the insurance, access to insurance. We know that patients, they move. Sometimes they're coming from another county. Sometimes, we see older survivors. Children can generally stay on a parent's insurance until the age of 26. So for patients who do have that employer-sponsored health insurance, we counsel about those changes to the ACA that happened about 10 years ago. Also, cancer is no longer considered a pre-existing condition if someone were to go purchase insurance on the private marketplace. So that's something that we teach. And just really also looking at social determinants of health. And this is something that we do every visit. We look at access to stable housing, access to food. We know that the social determinants of health are all the non-medical factors that can determine someone's ability to access care and to receive care and to stay healthy.
All right, so this is a new section that was added with version 6, subsequent malignancy and risk of malignancy in offspring. We know that there are certain cancer diagnoses that increase the risk of developing other types of cancers as you get older. And it's usually related to the genetics from their cancer diagnosis. So here are some examples: retinoblastoma mutation, neurofibromatosis, Dicer mutation, P53. One example is retinoblastoma. Patients who have the retinoblastoma gene are at higher risk for developing osteosarcomas, bone tumors, as they age. So we educate families about that and symptoms to monitor for and to let us know if they are experiencing any pain, lumps in their bones, limping, anything that is new. Children of cancer survivors with a known genetic mutation should be tested after birth, and our oncologist can help get that set up. And that's especially important with children who had the retinoblastoma gene. Their children need to be seen in ophthalmology clinic within the first few weeks after they are born. Genetic testing is done at the first visit. No screening yet. They wait to see if the child has the retinoblastoma gene. Then they do begin eye exams under anesthesia. If it is negative, then no screening is needed because there is no increased risk of that child developing retinoblastoma. There are also some other criteria, bilateral cancers like bilateral Wilms tumor, having more than one primary cancer. Say a patient who had Wilms tumor, received radiation, developed Ewing sarcoma as a secondary malignancy, just screening them for further malignancies as they get older, a first-degree relative with cancer, or a concerning family history where someone in the family was diagnosed with a genetic mutation like P53 Dicer mutations. So that is new. This is an example. So I was explaining before that we put together do a chart review, put together a life care summary. And this is an example of one patient who was treated for standard risk ALL. We list diagnosis, date of diagnosis, date of completion of therapy, whether they were high risk, low risk, age of diagnosis, where they were treated, what chemotherapy regimen was given, chemotherapy names, total doses of specific chemotherapies, intrathecal, and then the dose equivalent. We talked about that earlier. How much doxorubicin or cyclophosphamide tells us how high a risk someone is for heart issues or fertility concerns from those treatments. And then you can see at the bottom, radiation therapy given none. We would fill that out if someone received radiation. And then further down is also surgery and bone marrow transplant if they received either of those treatments as part of their treatment regimen. And this would be, our risk-based information that we give our patients. This is, I'm going to have two examples. So one, this is from a standard risk leukemia patient. They received cyclophosphamide and doxorubicin. So from those treatments, they're at risk for acute myeloid leukemia, myelodysplasia from the cyclophosphamide, and acute myeloid leukemia secondary to the doxorubicin. And then we put together a plan, and this all comes from the risk-based guidelines from the Children's Oncology Group. We do a CBC with a differential annually until they're 5 years off therapy. We do a full history and physical with every visit, looking for fatigue, bleeding, bruising, bone pain. We do a skin exam looking for anything that the family may have missed. We do that up to 10 years off therapy. And we teach them what to look out for. So if they notice they're more fatigued than usual, parents notice they're pale, bruising more frequently, bone pain, something that they should always let us know. And then, CBC bone marrow if clinically indicated. And then here is another one for, this is the same for standard risk ALL. They receive doxorubicin, which can cause cardiac toxicity. So baseline echo and EKG, although as I said before, with the standard risk, they receive such a low dose that really the recommendations don't recommend frequent monitoring, but we do like to get a baseline echo and EKG just to make sure everything looks fine as they come into our clinic. And then what to assess for: shortness of breath, chest pain, palpitations, any history of nausea, vomiting, what to check, of blood pressure, and cardiac exam. And then we also just encourage healthy behavior, exercise. As far as we know, exercise is generally safe, and we encourage it in patients who have normal heart function. If they are higher risk, we do have specific guidelines with exercise restrictions should they be needed. And this is some information for families, the Children's Oncology Group. This is the connection to the guidelines. That is what's listed on top. And health links. So patient information that is put together from the Children's Oncology Group about everything that we discuss with families. The first one's on top on general and psychosocial. We pretty much give to everybody. And then the other ones are based on treatment exposure, whether they've had chemotherapy. If they didn't have chemotherapy, we may not give dental, but anyone who had chemotherapy, we're going to give dental. If they've had anthracyclines, heart health. If they've had radiation to the head or neck area, some of the endocrinology late effects. So this really just depends on what their treatment exposures were. We print out the appropriate health things and give them to patients at their first visit. And as you can see, they're available sometimes in multiple languages so that we can print out so that the families can read.
I will just want to jump in and say many of the patients we see are very young, maybe 3, 4, 5 years old. And so we typically refer back to these guidelines because the education happens at every visit. So as we get a child who's nearing adolescence and adulthood, a lot of our education shifts from the parents to the actual patient. And so frequently I will reprint these health links, especially on mental health, school after treatment. There's a lot of great information for how to get support, supportive services, special education services in the school setting. So I just wanted to jump in and say that we print those initially and then as needed, and these are available to the public so anybody can go and print these based on their interest.
And we really include the patient from a young age in our visit, ask them questions about their health, how they're feeling, and try to teach them about what they should be aware of in terms of their body and how to keep themselves healthy. Even from the age of 6, 7, and 8, I, start asking the patient more questions than the parents. And, I think that's really important for them.
It's really important that we teach self-advocacy. As in our name, we're the transition service too. So we support a lot of our patients in transferring to either adult primary care or to adult survivorship care. So we really hope by the age of 2021, patients are as self-sufficient as they can be in having that information so they can speak up and feel like they have a voice when they go see their providers when they leave us.
And if you look at the bottom on the right, there is a directory of long-term follow-up services. As our patients age, they move, sometimes go to college, out of town, families move to another state, another city. And there's a directory of long-term follow-up clinics all over the country. And we can provide those clinics, phone numbers, connections with them to help get set up in new cities as they move. We've even had patients study abroad, and we, just schedule their live visits around their trip. I saw a patient last month or the day before they left. We saw them for their life visit, and then we scheduled a follow-up for right after they return from their trip. So we want them to experience everything that they possibly can.
Right.
And here's one example, and this is a newer one, vaccines after treatment for cancer. For patients who did not receive a bone marrow transplant, we basically pick up after we left off wherever they stopped when they were diagnosed, because as you know, vaccines are on hold during therapy, and there are certain restrictions during that first year off therapy. So after 6 months, they can get killed virus vaccines, after a year, live virus vaccines, but there is a fear sometimes about starting up the vaccines again, worry about their immune health. So this is to kind of reassure them that it is okay for them to receive vaccines. There is another one for patients who did receive a stem cell transplant, because after transplant, we do re-immunize, start from the beginning. And there is a special schedule based on international guidelines on how to re-immunize patients after transplant. Within the first year of therapy, we do encourage our oncologists to refer patients to our clinic. They will still see their regular oncologist for disease surveillance up until about 5 years off therapy. Life Clinic is an annual visit, and that will continue till patients are age 20 and 5 years off therapy, whichever occurs later. So if someone diagnosed at 18, finished treatment at 20, we will still see them in our clinic until they are around age 25. We have a patient portal that both patients, parents, and their primary care doctors can log in, have access to all their medical information from lab results, physician notes, including our Life Clinic summary, scheduling appointments, and emailing all their providers. And we encourage at each visit, if a patient has not signed up, to do so that they can have access to all their medical information. In terms of transfer, so once people hit both criteria, we look at risk, how high risk is a patient for late effects in the future. So patients who are low risk, low dose chemotherapy, such as a patient who had ALL, Wilms tumor, who had low dose chemotherapy, no radiation, no transplant, we will discharge them from oncology with the goal of having them seen by their primary care doctor once a year for an annual screening. And then they should have access to our Life Clinic summary through the portal to know if there is any extra screening that is needed. For patients who are high risk, like high dose chemotherapy, radiation, transplant, and have a genetic mutation that increases their risk for secondary cancers as they age, we refer them to our adult survivorship clinics. And we have 2 that we send them to. It's really insurance based. Different hospitals take different health insurance, and we do whatever we can to help guide them in the right direction, prepare them for transfer, and help them with the transferring over of paperwork to the adult clinic.
So here we have 2 different QR codes. The one on the left, if you want to scan that will take you directly to the phone book size guidelines. I don't know if you can see my finger, but it's about, 4 or 5 inches thick, the guidelines in printed form, but they're easily accessible and easy to read online. And the QR code on the right takes you directly to that health links page that we just showed, with the printable health links, the directory, and another resource guide for survivors. So you can also just go to survivorshipguidelines.org. We do provide this information at every visit, and it's written into the Life Clinic summary. So when the primary care doctor is reviewing that and has a question, they can easily access those guidelines as well. But we really, as Ellie just mentioned, and I said, we really want to empower patients and families to know what their risks are, most importantly, so they can manage the risk, right? We talk a lot about risk in oncology, and there's risk you can manage and risk you can't really manage. So let's focus on the wellness behaviors, the annual screenings, paying attention to the body, and checking in with the caregiver or following up with the doctor if there's a concern that needs to be further addressed. So with that, I believe we've come to the conclusion of our slides. We are more than happy to answer any questions. We are also available offline if you had a particular question or there was a resource that you were curious about. Don't hesitate at all to reach out to Ellie or myself. We have our email addresses there. Again, thank you so much Cancer Support Community LA, Abby and Jennifer. We really enjoyed spending this time with you and hope this was of benefit to you all. Thank you.
Thank you so much, Lisl and Ellie. It was a really informative presentation. With that, we invite our participants to put any questions they may have into the Q&A feature found at the bottom of the Zoom window. It looks like we did receive one, so I can go ahead and get started with that. So someone said their daughter is 15 with HR ball leukemia at CHLA. How soon after their daughter rings the bell, hopefully April 2027, will they be seen at the clinic?
They'll probably be referred within the first year after completing treatment. The earliest I've seen is about 5-6 months off therapy. It's really primary oncologist dependent, and you can let them know to feel free to talk to their oncologist about it, that they heard about the Life Clinic and it's something that they're interested in and would like that referral. But most oncologists will make that within that first year off treatment.
Perfect. Thank you so much. If anyone has any other questions, please feel free to put them in the Q&A. If not, I will get started with the fee that we received during registration. So someone asked, do you have any strategies for sustaining engagement with follow-up care across the long term?
Well, because we only see our patients once a year, generally after that visit, we give them an appointment for the following year. It's hard to know what you're going to be doing on March 11th, 2027, but if we saw a patient today, you know, they stay on our radar. We do encourage patients and families to log onto the portal, to read their report, to look at the lab results, and then, you know, between one visit to the next, we encourage them to see their primary care physician, and we also really expect our primary care providers to also make sure that the patient is receiving long-term follow-up, especially until the age of 21, if as indicated. For our patients that transfer out, we do have a system in place. We have a wonderful nurse care manager, Amy, and she does make follow-up phone calls within about a year of that last and final visit at Children's Hospital, just to simply check in, to see if they've had any medical issues come up, to see if they are actively seeing their primary care provider at least once a year. If they have any questions and concerns, she can guide them. And then I, as a social worker, I continue to remain available to patients and families years afterward for any kind of resource support or direction that I can give as far as community linkages.
And we give them paperwork with all of their transfer visits, with all of our contact information, so that they can reach out to us anytime. Even that's what I tell them, even though we're not seeing you on a regular basis, you're more than welcome to reach out to us. I had a patient who we discharged at 20. At 27, he called and he said, you know, I want to look at my chart. I want to see, how did you decide what chemotherapy you gave me, how much? So we brought him back in again 7 years later, brought his chart out so that we could look through the roadmaps and how we made those decisions, so he could better understand why he received the chemotherapies he received and why he had certain risks for late effects in the future. And I think I haven't heard from him again, and I think it really made a big difference.
Perfect. Thank you so
You
much.
know, I'm just going to piggyback on that too. I think what makes a children's hospital and pediatrics a little different than adult medicine is that if you don't come to your appointment, we're going to call you. We're going to track you down. We're going to explore what the barriers are. If it's just, you know what, I'm feeling great, I just don't feel like I need to do it right now, that's okay, right? We want to give patients that autonomy and that decision making. We will, reinforce why we think it's important, but honor their, decisions and help them, whenever they decide to call us back if they need to. But maybe there is a transportation barrier or an insurance barrier. So we look to see what those are and provide any kind of assistance where we can facilitate a return visit as best we can.
Perfect. Thank you so much. And then we have one other question. What recent policy changes at Health and Human Services have been impacted by the impacted the guidelines?
I haven't noticed any at this point. We don't seem to have any problems with getting scheduled any of the tests that we've ordered or getting insurance approval. Sometimes we cannot get testing done at CHLA, and that can be done through their HMO or primary care doctor closer to home. But that was something that has happened, before. This is not something new. It's really all insurance based, but I have not personally noticed any changes.
Right. As in our day-to-day practice, we haven't noticed significant changes to access to care. However, with the pending threats to funding cuts in Medicaid and certain populations no longer having access to fee-for-service or full-scope Medi-Cal, we anticipate if those budget cuts continue or worsen, that's going to be very limiting for some of our patients and families. We have quite a few patients who have their health insurance through the marketplace or through the exchange. And with the ACA subsidy credits expiring, unless Congress and the president, turn that around, I worry that patients that, are middle income that won't necessarily have access to Medicaid, which is intended for lower income families, and they may not have the ability to afford private insurance through their employer even. I worry that that's going to prevent access. We also see some just general, skepticism when it in regards to evidence-based medicine. So again, we provide a lot of information for families to get factual information through, for example, the survivorship guidelines, through the American Academy of Pediatrics, to really, when they're seeking advice, medical recommendations, to look at trusted sources rather than following, sort of blips on the news or things they might see on social media.
Perfect. Thank you so much for taking the time to answer all of our questions and for being here with us, Lisl and Ellie. We truly appreciate it. We do have one final closing slide. I can go ahead and share my screen. Thank you everyone who joined us today. If you would like to learn more about Cancer Support Community Los Angeles, please visit our website at cancersupportla.org. And if you have any questions, please feel free to email us at info@cancersupportla.org. Lisl and Ellie have graciously agreed to share a copy of the slides. So if you would like to receive a copy, please feel free to email us. And with that, I will pass it over to Jennifer, who will give us more information about our Child, Teen, and Family program.
Yeah, thanks so much, Abby. And thank you to Lisl and Ellie for such an informative and meaningful presentation. I just want to share a little bit about our Child, Teen, and Family program here at CSCLA. So we provide support for families with children under the age of 18, including children living with cancer and youth that have a parent, sibling, or other family member with cancer. And we create a safe and welcoming space for families to be able to connect, learn coping skills, and have fun through programs, including groups, individual counseling, educational workshops like this one, and social gatherings. You'll see the flyer here is for our new 4-week series of creating connections for kids and teens groups, which are going to be on Tuesdays from 5 to 6 p.m. beginning April 28th through May 19th. These groups provide a fun and safe space that offers participants the opportunity to make new friends and feel supported and understood by others who are going through similar experiences with cancer in the family. I'll also mention we have a Creating Connections for Parents group on the 3rd Tuesday of each month from 6 to 7 p.m. as well. And this group provides the opportunity for parents to come together with other parents to connect and gain support while coping with cancer. This group is open to parents of children with pediatric cancer, parents who themselves have cancer, or parents who have a co-parent living with cancer. If you're interested in joining one of these groups or would like more information about our programs, please don't hesitate to reach out. We're here to support you and your family. Thank you.
Thank you so much, Jennifer. With that, I want to thank Lisl and Ellie once again. We really appreciate you being here with us. And please feel free to reach out if we can be of any assistance. And we hope to see you all at a future webinar. Thank you, everyone.